I'm going to start with a rider at the beginning to say that this does actually feature quite a lot, or nearly all, is work that I've been involved in, or my colleagues have been involved in. Well, I do mention other people, but the reason why is because I know that you're a very demanding audience and you'll want to ask me lots of questions, so it's better that I talk about what I know. So, what will we discuss today? Well, I thought we'd first of all just remind ourselves once again of the current evidence for treatment of OCD. I'm then going to do a study comparing ERP with using an SRI. Then to look at supranormal dosages, forgot my teeth this morning, of SRIs. Look at some alternative treatment methods, including deep brain stimulation, transcranial magnetic stimulation. And then, because Colette specifically asked me to, I'm just going to race through some of the obsessive-compulsive and related disorders. Okay, so what do we know about OCD? Well, we know that OCD tends to run in families. I've just been upstairs at the art project in OCD and hearing somebody that was talking exactly about that. And so there is a genetic component, but it's not quite so straightforward as just a straight genetic thing. It's not quite like eye colour or hair colour. It's a little bit more complicated than that. We know that it responds to psychological treatment involving CBT, and that has to involve exposure and response prevention. We also know that it responds to treatments with drugs that act on the serotonergic system. That's a messenger in the brain. So the drugs we talk about, as most of you will know, are serotonin reuptake inhibitors, which means clomipramine, or one of the more selective serotonin reuptake inhibitors, or SSRIs. We know that approximately 2/3 of people with clinical OCD will respond to ERP alone. And we also know from separate research that about 60% of people with OCD will respond to treatment with SRIs in adequate dosage. However, it's worthwhile saying that some people respond to one drug and not another. So in other words, if one drug doesn't work, it's always worth trying another. But despite many studies over the years, one thing we don't know is how do medication and CBT involving ERP compare? Do the same people respond to medication and to ERP? Or is it different people responding to each differently? Are they equivalent? And what about relapse? Now then, it might surprise you, but one of the problems is there are a lot of studies, but there's always a lot of problems with studies, and I'm not going to solve all of them, but I'm just going to raise some of the problems that studies have. When we come to studies on CBT, these are almost always terribly, terribly small numbers. Very, very small numbers. And therefore, it's quite difficult to make proper judgments from that if you've got 10, 15 people, because you don't know if that's going to be the same with 1,500 people. Many of the studies have been performed in participants that are also taking medication, and that can actually confound the results, and often that has been ignored by researchers. There's always a tendency that you report studies that have a positive outcome. Negative studies tend to be dismissed and swept under the carpet. There's also, in the researchers very often, they have belief systems, and there's maybe an unconscious bias towards the treatment being successful. And although a lot of studies are what they call blind, so that the person doing the research doesn't necessarily know which treatment they're on, there are ways of knowing. you know, the study participants do tend to let it drop, let it slip, or maybe the therapists themselves may do. And also follow-up periods are often short, and so there's no real record very often of relapses. I think the longest ones I've usually seen in general are sort of 1 to 2 years if you're lucky. What about studies on drugs? Well, they tend to be larger. They tend to be funded by drug companies with lots of money. But there may also be much more of a pressure to find a positive result. Again, there's an issue with the tendency to report only studies with positive outcomes. Again, there's probably an unconscious bias towards the treatment being successful. And again, it's possible for even a blind researcher to work it out, because people might talk about side effects that they know are more common with the drugs. Again, follow-up periods are often short, and there's no record of relapses. And also, it's difficult to know if the participants have actually taken the medication or not. So, in true Blue Peter style, I'm going to say there hasn't been a study which addresses all of these points, but here's one we started earlier. In sticky back plastic. This has been funded by the NHS, not a drug company. We've had researchers who are predominantly working in psychopharmacology and others working predominantly in CBT. We wanted to plan, this is with Professor Feinberg, and Naomi Feinberg and I have been talking about this and submitting grant proposals for this. I think our first one was in 1990, and I'll come on to this. We want to have at least 90 per treatment arm, and we want a follow-up of at least 2 years, if not longer. So far, we've only had the money for a feasibility study, and I'll tell you what a feasibility study is. And there's a list of the feasibility study. These are the people that have worked on it. As you see, there's Professor Feinberg, David Baldwin from Southampton, myself, and a lot of fantastic people from all 3 sites. What this study was looking at was aiming to compare sertraline, increasing up to 200 milligrams a day, if at all possible, because we know that's most likely to be effective, or CBT involving ERP. We had qualified therapists, and as well as being qualified to deliver that, they also received extra training from myself, and I produced a manual, and we had regular supervision. So a feasibility study is one which is performed to make sure that a full study will be possible without the NHS having to commit to the financial investment of a full trial. And it's to prove that we can get people to do this and to prove that it actually works. But because the numbers are small, again, the results have to be treated with caution. The study, as I said, was at 3 sites. There's Hertfordshire Partnership Trust, ourselves at South West London, and the Southern Health Authority Foundation Trust in Southampton, with David Baldwin. The plan was to get 120 patients to be screened for a diagnosis of OCD and asked to participate in the study. And naive as we were in those days, we thought that from that we'd get 60 eligible consented patients who would be ready to take part in the trial. As you see, we're not doing any experimental treatment. These are all standard, nice, approved treatments. And the 3 treatments were sertraline, CBT with ERP, or sertraline plus CBT plus ERP. Now, sorry, for some reason I can't get this to move. I'm not very good on the thing, so I do apologise. I'm not going to give you all the exclusion criteria because that goes on forever and is very boring, but basically community-based service users aged 18 to 65, diagnosis and sufficient severity of OCD, and OCD for at least a year. So here we go. We approached 259 people, and we excluded 210. 49 were found not to be suitable. They either had a completely different diagnosis, their OCD was too severe. We wanted mild to moderate. We didn't want people that were in the category of refractory. They were either pregnant or were not on adequate birth control, or they'd failed too many previous attempts at treatment. 152 people who were suitable refused to take part. And we are now following that up in a bit more detail as to what the problems were. But mostly it was, I don't want to be a guinea pig, which is interesting considering these are all the treatments you get anyhow. I want to choose what treatment I want, or it takes too much of my time. So interesting response, and it does mean that when we go on to the full trial, we are looking at having an arm where people actually do choose their treatment as well. But I am worried that everybody will want to go in that, and it might skew the whole trial. So 49 people were found to be suitable and agreed to take part. 16 were randomized to ERP, 15 to Sertraline, and 18 to CBT plus Sertraline. This is a very complicated slide, and I've just put it up just in case anyone is really very interested in it. Does this slide work? No. Yes. So at baseline there were 49. By week 52, we only had 23. Of the CBT people, 16 to 8, so 50%. SRI, 15 to 6. So as you see, it's approximately half. Because of this, we could only actually analyse meaningfully to week 16. And even then, I'm a little concerned at the dropout rates there. So we're also looking at why people dropped out. Is it that they felt much better and went off into the wide blue Londa, or is it something else? Here's the results in terms of the Yale-Brown Obsessive-Compulsive Scale score. And I think many of you will be familiar with that. The maximum on that is 40. As you see, people here started just in mostly the severe range. If you see these lines going up, that gives you what's known as a standard deviation, or it gives you the idea of how much variation there was between individuals. And lower is better, so people are overall coming down on all of their measures. But really, we can only go to week 16 to really analyse any of the data. We also had a health economic analysis from the University of East Anglia, and they came back and said, well, looking at these data, compared to sertraline alone, CBT was much more expensive. And CBT with drug was even more expensive. And that's true, but that's true to a year. And I think what's interesting with that is if you were then to go for a lifetime, of course, if you're on a lifetime of sertraline, how does that compare to, and we need to really look at the relapse rate. So, any interpretation of this, you need to come with a government health warning printed firmly on the outside of the packet. The numbers are extremely small. The economic benefits were only measured to 1 year, and of course we've taken these results, we're looking at it, and we're hoping to construct a much more robust full trial. Far fewer people were willing to participate in the study than in most other conditions, even in mental health. And I suspect that we were quite demanding in wanting people to come and being tested on a whole range of measures to be completely thorough. And I think these were people that had mild to moderate OCD, whereas certainly Professor Feinberg and myself are more used to seeing people with severe to profound who may be a bit more motivated to attend and to come, whereas people with mild to moderate have got, rightly, lives to get on with. It did look as if treatment with both CBT and SRI, both were effective, even with the small numbers. But we do need to perform the full study. So that was just a little taster to tell you, and I'd be interested if anyone has any other ideas as to how we can get people with mild to moderate to participate in this, because as I think we'll all agree, it is actually an important study.
Did geography play a part? Because
no, they were local. They're all local to us.
So I mean, because there's such a disparity between the South and the NHS Trust in the South of England, say.
No, but they were all local people.
How do you mean local to this trust?
To our the three trusts, yeah.
Yeah, so if you look, it's very southern centric.
Yeah.
So if you look in North England, North Wales and the Welsh trusts.
Yeah. Well, yeah. Well, what we're looking at is actually, we've got a couple of people that we want to incorporate next time in the North East and North West. Yeah. Okay. I wanted to talk to you a little bit about sertraline and blood levels. We know that OCD tends to only respond to SRIs in higher doses. It's much higher than in depression. You need to be at the top end, really. And I'm going to give you the normal doses for OCD in the next slide. And here they are. At least 225 of clomipramine, 300 of fluvoxamine, 60 paroxetine, 60 fluoxetine, at least 200 of sertraline. I've put citalopram and escitalopram in red. I've done this before. This is because the drug company reduced the recommended maximum dose a few years ago. The actual real strong evidence base is for 60 of citalopram or 30 of escitalopram, which is now off license. It does mean you can prescribe it, but the individual needs to fully understand and consent. Can I take questions at the end? Is that all right? I'm sorry, I can't hear you. This is adults. This is adults. It obviously has to be titrated down for children, yeah, depending on their body weight. Because there tends to be an increase in the positive response to SRIs, the higher the dose, it's been suggested that some people who don't benefit from SRIs may need higher dosage than normal. But bear in mind, clomipramine should never, ever, 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 ever be given in more than 300 milligrams a day, because it's actually a bit, it's dangerous. Okay, so there's been evidence that this works from naturalistic studies. There's been a couple of papers, and my friend and colleague Elenia Pampaloni, who works with me now, published a very good naturalistic study looking at higher than normal doses of SRIs and the response they produced. We became interested that some people on higher than normal doses of sertraline with refractory OCD, that's OCD that doesn't seem to respond very well to anything, or hasn't in the past, had blood levels within the range expected for normally prescribed doses, or even lower, so that you could go higher and you were not getting high blood levels. And here's a slide which I'm going to explain to you. And again, I've produced it myself, and I'm not always very good on producing things on PowerPoint. This is the dose of sertraline. So a normal dose is here. They're all on higher than normal. And if you, this is actually 250. If you go to 250, this is the range of blood levels that we had. Now then, they should be lower than 300. So they're all lower than 300, but some are higher than others. But look at this. There's people that actually went on 400 are still within the low dose, very, very low dose, apart from this person who responded there. So despite being on above the manufacturer and everybody's recommended prescribed maximum dose, we're getting people within the normal range and a wide variation. And I should say, actually, that these people here, everybody always imagines they will be 6'6" rugby players, and it's not true. Not true at all. There are diminutive little 7-stone ladies there. Can I take questions at the end? Because otherwise, sorry. Yeah. Okay. So, all blood levels were within therapeutic range. So this suggests either, is the person not taking the medication? We always have to think about that. That's less likely in such a large number when these were all my inpatients, because when they're inpatients, as you may know, a nurse hands you the medication and you take it. So you can not take it, but you've got to be pretty good at not taking it. Is the individual not absorbing the drug correctly? In general, the absorption of SSRIs is good, and the peak blood levels should be seen after 4 to 6 hours. Or if, as we suspect, the individual has a very effective system, mainly in the liver, breaking the medication down more rapidly. And there have been some specific genetic findings that suggest that there are some people that have these enzymes that break this down more rapidly. It might sound really good to have such an effective system, but it's probably not very good if you've got OCD and you're wanting to get over it. Okay, so that's another thought for the day. What about other methods of treatment? Well, I wanted to talk to you about deep brain stimulation, because the last time I talked to you, I think we'd just started a deep brain stimulation study. About 100 people now with what's called severe OCD have had deep brain stimulation treatment in Europe and North America. They've said severe. I'm a bit worried about what they mean by severe, because from a lot of the places it's not what I think of as severe. I was talking to somebody that does a lot of deep brain stimulation and was talking about some of the difficulties of the people I have as inpatients, and saying about people being incontinent of urine and feces when they come in. And he said he'd never seen anyone have that. So I suspect that they're very often treating people that we would treat effectively in other ways. 2/3 of the people across these studies, I've ignored, by the way, the Chinese data. The Chinese do deep brain stimulation with everyone with a Y box over 20, but their human rights record is not something that I wanted to use their data. But 2/3 have had a significant response, and the criteria usually used for OCD on the Y box, which is not the most sensitive of measures, is a 35% reduction. So, as I say, the definitions of severe have been variable. So we wanted to look at what about those people who are the most ill, who've not responded to any treatment. Currently, the only option they have is neurosurgery, which in the UK. And I wanted really, I was just saying to somebody else, I've been the consultant in charge of a unit in my hospital for 33 years now. And there were some patients that I'd known for well over 20 years who had had multiple treatments, and with the best will in the world from me and from them, had failed to get better and really had very restricted lives. And that's the kind of people that I think we need to be addressing more, because I see people that actually their lives are tragic. And obviously, any decision like that has to be the individual's decision, it's not mine. So we set out with a Medical Research Council grant to examine the possible role of deep brain stimulation in people with the most profound OCD symptoms who failed multiple trials of treatment. It was the surgery, etc., and the lead was at the National Hospital for Neurology and Neurosurgery here at University, just up the road, University College London and University College London Hospital. Then there's from the Specialist OCD Network, ourselves, again, Professor Feinberg, and also some input from Professor Keith Matthews from Dundee. And because we wanted to make very sure that when you're mucking around with people's brains, you get what you've advertised on the tin and nothing else, we did extensive neuropsychological tests before, during, and at each stage of the way, with with the absolute leading lights really in this area, with Barbara Sahakian, who many of you may have heard on the radio many times, and Trevor Robbins. Okay, there's been a lot of work on deep brain stimulation. There's a circuit, but different sites have been used. So we reviewed all the previous studies and decided to choose two particular sites, the subthalamic nucleus and the ventral capsule, ventral striatum. And we wanted also to investigate the relative effect and effectiveness of stimulation at each of these sites. This is just trying to simplify what we actually did. People had surgery, and they were then randomized as to whether they had the ventral, well, let's just call them VC, VS, or the STN, stimulated first. After 3 months, they were crossed over. They then had both stimulated. Then they sat down with everybody and decided what for them was the preferable site. They were then left on that, and then they came to ourselves and had CBT with ERP for the final 3 months. I've been very careful not to reveal who any of these people are, and if you think you know who they are, you probably don't. There was 1 woman and 5 men. Why? Just the way it happened. It would have been nice to have had more even numbers. The age of onset of most of these people was actually very young. There's 1 or 2 that were older. The age at surgery, again, varied from 38 to 62. Nobody was living independently. Most of them had multiple hospital admissions. Some were completely unable to cope without being fully in an inpatient unit at all times. So the quality of life, I think I want to get over to you, was grim. Here's what happened with the deep brain stimulation. Again, this is Y box. Higher is worse, and again, we've got these funny standard deviations, but don't worry too much about those. This was at the start. This was when the STN was stimulated, so on average, people were going from profound down to moderate when STN was OCD when STN was stimulated. VCVS coming down further still. When both were stimulated, we were into the realms of mild OCD. It was then decided on some optimization. You'll see that that goes up a little bit because there were things that people didn't like about what it's not just treating symptoms, you're treating an individual. So they were prepared to go for slightly worse symptoms. And this was after we did the CBT. This is a depression rating scale. The Montgomery-Asberg depression rating scale. As you see, they all started with moderate depression, and the overall trend is in pretty much the same direction, and they were ending up overall with either normal or very mild depression. Sheehan Disability Scale, I like the Sheehan Disability Scale because it measures how you're functioning in your home, your family life, your work life, and your social life, all of which are important aspects. And 30, I'm not very good at doing these graphs, I'm sorry. 30 is the maximum. And so people were scoring to begin with almost the maximum. And then they were functioning very much better. So, with this study, DBS seems to be effective in our group of participants, mostly with dramatic changes for a better lifestyle. All are now living independently. I talk to them quite regularly, and the kind of comments I've had in the main from people that have found it a very useful experience is, I wish I'd had this years ago. We don't want to just leave them at that, so we're continuing to follow them up every 3 months. We've done so for the last 3 years. The aim is to continue doing that indefinitely. And we'll be looking for people to take over from us for some of these people when we move on. And we still monitor any problems which arise. Okay, are there any less invasive non-surgical biological treatments? I don't know if David Adams here, but he was talking to me before about the whole question of transcranial magnetic stimulation. And transcranial magnetic stimulation is trying to do the same as deep brain stimulation, but it does it by applying magnets outside the head. So no surgery. And by that, you zap certain areas and wipe them out temporarily. So therefore, it's very safe. It's really, even 4 or 5 years ago in the States, there were people trying. I went to go and get a Mars bar because I was hungry and I hadn't had lunch when I was in New York. And the people that were offering free Mars bars were selling transcranial magnetic stimulation machines, and they were very keen that I should buy one. And I was just imagining the expressions on some of my managers' faces in the NHS if I came off the plane and brought this in. Shows you not to have a Mars bar. Wasn't worth it. Okay. The studies that they've done on this are fairly small numbers so far, and it seems that the effect is short-lived and it needs repeating, so you need to keep on zapping. Seems to be effective, but it's short-lived. There's no real studies in the UK to date, but what we've been trying to get funding for, and this is what David and I were talking about, is to examine whether the effect of TCMS can be prolonged if combined with ERP. Is it that you could then get people to go really much further, the ERP, and would it then continue? So the answer is, at the moment, we don't know. And as I promised Colette, I said I'd talk about obsessive-compulsive and related disorders. Now then, obsessive-compulsive and related disorders are important and newish, although I think actually the last time I'd probably just come back from New York or San Francisco and was talking a little bit about that. At the American Psychiatric Association in San Francisco in 2013, the Diagnostic and Statistical Manual of Mental Disorders was launched, known as the DSM-5. For anyone that doesn't know, this is the Bible for researchers and clinicians, really, and lists the diagnosis that you can make. So if there's not a diagnosis, it tends not to be recognised and not to be looked at. And there were major changes in the description and classification of OCD. And what it was these were all put under the heading of Obsessive-Compulsive and Related Disorder of OCD. So there's Obsessive-Compulsive Disorder itself, Body Dysmorphic Disorder, Hoarding Disorder, Hair-pulling disorder, skin-picking disorder. Those are the ones I'm going to really talk about, because the others are OCD related to medical conditions or substance-induced, etc. Now then, body dysmorphic disorder up to then had been described elsewhere in DSM-4, but for hoarding disorder, hair-pulling disorder, and skin-picking disorder, they've not been described before at all. So basically, there's very little research on these. And so I'm afraid that's a lot of what I'm going to be telling you. And what research there is based on small numbers. I'm going to first of all start talking about body dysmorphic disorder. This is when somebody worries excessively about perceived flaws in the person's appearance. We've got David Veal here somewhere, I saw. Hi, David. Then David has, I think you've got a book that's there for anyone that you're selling today. Is that right? Yeah. And David is somebody who publishes widely on BDD. These flaws are unnoticeable or minor to others. There's very high risk of self-harm. We looked a few years ago and found that in our group it was well over 50% had suicidal ideation at any one time, and that we'd had over 30% had previous attempts at self-harm. We know that it responds, rather like OCD, to high doses of SRIs, and we know it responds to CBT, including ERP. So there is research on that, and David undoubtedly can tell you more. Hoarding disorder was one of these new, inverted commas, conditions. Indeed, I wrote a paper in 1996, I think it was, looking at hoarding. And there was nothing wrong with the paper, I can tell you, but it was very difficult to get it published in the journals because everybody said hoarding didn't exist, really. I eventually got it published in the Irish Journal of Psychological Medicine, for which I'm very, very grateful to the Irish, but it's not the most widely read and prestigious of journals, I'm afraid. In hoarding disorder, it's not due to OCD fears. A lot of people with OCD will have hoarding. This is something separate. So it's not due to contamination, loss of objects, or other mental or physical disorders. The studies in hoarding disorder are all with small numbers. There's some evidence for higher doses of SRIs, but mostly that's with people also with OCD. So, again, the work hasn't been done to drag it out. And there's some evidence for dopamine blockers. So that's what you might call antipsychotic drugs, but at a much, much lower dose than you would use for psychosis. There's some evidence as well for CBT, but what we do know is it's time-consuming and a long-term therapy. So I want to show you a recent study examining the possible role of a hoarding group, a hoarding treatment group, not a support group, that my colleagues in our trust-wide service, Augusta Chandler and Robert Fogg, are still continuing, but these are their preliminary results. And this is just with 15 people treated in a hoarding group. They give different measures here. That's acquisition, difficulty discarding, clutter, and the total scale. And that's at the beginning of the group, at midway, and at the end. And this is what's known as intention to treat analysis. So if anyone dropped out, they carried forward the last measure they had. And we're quite excited by this because these results seem to be better than have generally been recorded. Again, it's very small numbers. They've now got 20-something, 26. We're trying to get more and more, looking similar. And it does appear that getting people into the group and doing therapy in the group may actually encourage people to change a bit more. So we're quite excited by that. So watch this space, and if I get invited back on 3 or 4 years, I'll tell you then. Okay, then trichotillomania, or hair pulling. This is the urge to pull out hair, either on the head or other bodily hair, including eyebrows and eyelashes. Once the hair is pulled, it's often described a sense of relief or even pleasure. Very little research. It's always been said that CBT involving hair habit reversal training can be useful. And I think my colleague Alex is talking about that this afternoon, aren't you, Alex? But actually, again, most of the studies are very small. There's been some suggestion that CBT, including mindful acceptance and commitment therapy, may help. Tiny, tiny numbers, so I can't recommend any of these as it was. And also, again, small numbers, treatment with clomipramine. And then N-acetylcysteine, which is a health food addition, can be helpful, or olanzapine, which is used as an antipsychotic drug, but again, in smaller doses. So the answer with trichotillomania, I'm afraid, is watch this space again. And the same with dermatophilia or skin picking. Again, here there's an overwhelming urge to pick at the skin to the extent that damage has occurred. There's very little research. Of course, this is also frequently seen with people with body dysmorphic disorder as well, and also with people with OCD. For the skin picking itself, it used to be called a lot of things. I published a paper in the late 80s in the Journal of Dermatology about somebody who'd had a few spots, a bit of acne, and then developed a full-blown skin-picking disorder. But despite it being unknown, there's been very little research. So habit reversal was certainly what we used in the 80s, and there's probably more people have more evidence for that in CBT terms than others. Some suggestion that mindfulness and acceptance and commitment therapy may be helpful, and evidence for SRI, N-acetylcysteine, or naltrexone. Okay, so that's what we've done. I'm not going to go through that. I'm also a bit like if you get invited onto the Graham Norton show, you always have a book to push. And I'm going to tell you that I've got a book coming out in July. I've got some flyers here that I've also poked them around in various other places. What this is really 40 years of working with OCD, looking at what my understanding is, and it covers adults, children, CBT, drug, brain surgery, and some of the stuff I've talked to today and more in terms. I've subtitled it, All You Want to Know About OCD for people living with OCD, carers, and clinicians. So it's aimed to be available to the lay public. Okay, any questions? Right. Goodness, I don't know how to start here.
I was glad that you brought up these other disorders because often people have dual diagnosis. And as someone who suffers with severe OCD and hoarding, I'd like to know if any work or research or anything is being done on the impact between one disorder and the other, because for me, my hoarding is made worse by my OCD and vice versa. And it's something I'm not aware of anything and I feel is very important. And for me, I would personally find it very helpful if, as well as being taken separately, they could be taken together as to...
I think there is a difference, actually, between pure hoarding disorder and the hoarding you get in OCD, and that, I think, is the difference. And I think in terms of hoarding, hoarding with OCD is where most of the research has been.
Yes.
As I said, and that's the paper we published a paper in about 1996 on hoarding and OCD.
I've not come across anything myself.
And so there is evidence. There's some evidence for SRIs, as there is for OCD. There's evidence for, obviously, ERP, if that's the reason why you're hoarding. And so there's, in some ways, having OCD and hoarding is better news at the moment because we know more about it.
Yes, but it's something that I would like to find an alternative to medication, and a better understanding of it. It's as much about understanding it as anything else.
Okay,
yes.
Thank you.
Okay, thank you.
Thank you very much, Lynn. That was really informative. Firstly, can I just say Mars bar, top choice for lunch. Always my first go-to.
Yeah.
But on a more serious note, I find it quite baffling that, and I'm sure this isn't intentional, but there seems to be this false dichotomy between meds versus therapy, as if it's some kind of how much does this do and how much does this do. And in my personal experience, both have been really vital. You know, the meds got me in the place to actually be able to engage with the therapy. So I just wonder if you could say more about why you're sort of doing this kind of, what about this versus this sort of approach?
It's not so much this versus this. It's, if you look at the study, there were three ways. One was a combination. What NICE, NICE, National Institute, what they've said is that you start with one or the other, generally with psychological treatment, then put in medicine, and for the more profoundly ill people, you do a combination, the iller people. And we wondered if that was really true, and whether we know that the longer you have OCD, in a way, there's more chance that you have other effects on your life, your home, everything else. And so should we actually be going in, blunderbussing everybody with both or not? And that was another thing that we really wanted to look at, to see whether we should go for a wider approach or one or t'other.
8 or 10 years ago, when I was first undergoing treatment for OCD, there was quite a lot of hope for mindfulness as a treatment. I was wondering if you could update us as to whether that is still being considered or whether it's now largely been written off.
And again, it's very small numbers in all of the studies that we've seen. The numbers are small, so I think it's difficult to recommend that, particularly as we know that exposure and response prevention is effective.
Another therapy I heard about was acceptance and commitment therapy. Is that something that's... It was mentioned, I think, on one of the slides there for OCD.
Again, it's one of the so-called new wave, third wave CBTs. And again, there are people that are very, very pro this kind of approach. But the actual studies and the numbers involved have been so small, I can't really recommend it at that point.
Okay, one last question.
I'm quite happy to talk to people outside if you want to catch me.
Dr. Drummond, yes, thank you for your talk. I was just wondering, considering, can you hear me okay?
Yeah, it's all right. I'm a bit deaf, so I always come
All right.
and have a look to see your mouth move, you see.
Considering the NICE guidelines and the stepwise approach to treatment, how much do you think the relationship that the patient has with the psychologist when they're having CBT has a bearing on the success? Just in terms of when it's considered that you failed at psychological treatment and increase in medication is advised. How much of that is taken into account? And is another chance at CBT with a different therapist considered?
Yeah, I mean, I think that's an interesting point. And it's always a debate, really, because actually the therapy involved with the therapist is actually quite simple. It's graded exposure. But obviously, if you don't get on with somebody, your motivation may be less. Having said that, I would say that I've also had successes over my life, sometimes with people that will tell you that I am the devil incarnate, because they didn't like what I had to say. So, you know, yes, obviously a relationship, but sometimes people have actually got better to spite me, which is great.